Welcome to the Deep Dive. Today we're really zeroing in on a key topic for anyone prepping for the MSRA, renal artery stenosis.
That's right.
We've got some solid revision notes here, and basically our mission is to pull out all the must-know info and, make it stick. Consider this your high-yield guide to RAS.
Exactly. We'll break down what it actually is, why it matters clinically, and give you a clear way to think about diagnosis, management, everything you need for revision, basically.
Perfect. So let's dive right in. Renal artery stenosis. What's the absolute core definition we need to grasp?
Okay, so fundamentally, RAS, renal artery stenosis, it's a narrowing or blockage. It can happen in one or even both of the renal arteries.
Those are the arteries feeding the kidneys.
Precisely, the vital blood supply.
Yeah.
And the direct result of that narrowing is, well, less blood flow getting to the kidneys.
Okay, and is there like a threshold? When does this narrowing become really significant?
Yeah, there is. From a radiological view, if you see a 50% or more reduction in the diameter of the vessel, that's generally considered significant. And it's not just an image finding. It can cause real problems. Think hypertension, kidney dysfunction, less fuel to the engine.
Makes sense. Things start to go wrong. So what's actually causing this narrowing? What are the usual suspects?
Well, the big one, by a long shot, is atherosclerosis.
Ah, the plaque buildup.
Exactly, like furring up of the pipes, fatty deposits, cholesterol plaque. It just narrows the space for blood flow over time. But that's not the only cause. We also have to think about fibromuscular dysplasia.
Fibromuscular dysplasia. FMD. That sounds different from plaque.
It is, yeah. It's not plaque. It's more about an abnormal thickening within the artery wall itself. Less common, but important. And the notes also mention things like external compression.
Like something physically pressing on the artery.
Yeah, exactly. Or even developmental abnormalities. The artery just didn't form quite right from the start, but those are much rarer.
Okay, got it. Atherosclerosis and FMD are the main players.
Yeah.
So who's most likely to get RAS? What are the key risk factors we need to flag up?
The risk factors, well, they overlap a lot with general cardiovascular disease risk factors. So advanced age is definitely one.
Right.
Smoking is a biggie, direct damage to the artery walls. Then you've got existing conditions like hypertension itself, diabetes, high cholesterol. And it kind of stands to reason if someone already has a history of cardiovascular disease, like heart problems or peripheral artery disease, they're also at higher risk for RAS.
Yeah, it all connects, doesn't it? So how does that physical narrowing, the stenosis, actually cause problems like high blood pressure? What's the mechanism, the sort of pathophysiology?
Okay, this is really key to understand. When that renal artery narrows, the kidney senses, hey, I'm not getting enough blood flow.
Right, it perceives low pressure locally.
Precisely. And that triggers a really important hormonal response, the activation of the renin-angiotensin-aldosterone system, RAAS.
RAAS, a classic system in physiology. Remind us how that works again.
So the kidney releases an enzyme called renin. Renin kicks off this whole chain reaction. The end result is you get increased levels of two key hormones, angiotensin II and aldosterone.
Okay, angiotensin II.
That's a really potent vasoconstrictor. It tightens up blood vessels all over the body.
Directly increasing blood pressure.
Directly increasing it. And then aldosterone, it makes the kidneys hang on to more sodium and water.
Which increases blood volume.
Exactly. More volume, more pressure. So kind of ironically, the body's attempt to fix the kidney blood flow problem ends up causing high blood pressure throughout the body.
So if you see a patient with high blood pressure or maybe kidney issues, RAS is on the list, but what else should be? What are the main differential diagnoses?
That's a really important question, especially for exams. RAS isn't the only answer. You absolutely have to think about other causes of secondary hypertension, high blood pressure with a specific underlying cause.
Likely.
Well, primary hyperaldosteronism is a big one. The adrenal glands are just making too much aldosterone on their own. Then there's renal parenchymal disease.
So problems with the kidney tissue itself.
Exactly, intrinsic kidney disease. And less common, but still important, things like pheochromocytoma, that rare adrenal tumor pumping out adrenaline-like hormones.
Right, so it's a process of ruling things out. What about how common RAS actually is? Do we know much about the epidemiology, say, in the UK?
The notes mention that the precise prevalence in the UK isn't really well defined. It's a bit hard to pin down,
Okay.
but we do know it's seen more often in older people. That fits with atherosclerosis being the main cause, as that's more common with age.
Ah.
And it's definitely more common in people who already have high blood pressure and those known risk factors for atherosclerosis. We talked about smoking, diabetes, etc.
Okay, that makes sense. So what clinical clues, what signs or symptoms should make us specifically think, maybe this is renal artery stenosis?
Right, there are several red flags. Hypertension is key,
Hmm.
especially if it's what we call resistant hypertension. It's just really hard to control with standard medications.
Or if it suddenly gets worse?
Exactly. Or sudden onset hypertension in someone older.
Ah.
Also, a sudden decline in kidney function or kidney failure that you can't otherwise explain.
Hmm?
And another one is recurrent flash pulmonary edema, that sudden fluid buildup in the lungs, seemingly out of the blue.
Wow.
And then on examination, if you listen over the abdomen, sort of near the flank area, you might hear an abdominal bruit.
A whooshing sound.
Yeah, exactly. It's the sound of turbulent blood flow rushing through that narrowed artery. The notes had a mnemonic.
Go.
Bruit near the loins raises concerns for the kidney's moans. Something like that to help remember the area. Bruit near the loins raises concerns for the kidney's moans. Catchy. So are there particular patient groups where suspicion should be even higher?
Definitely. Someone presenting with new onset high blood pressure, especially if they don't have a family history of it, that warrants a closer look.
And having those strong vascular risk factors, we keep mentioning high cholesterol, dyslipidemia, smoking, diabetes, they really bump up the likelihood. And yeah, finding both hypertension and an abdominal bruit on exam, that's quite a strong pointer towards RAS.
And you mentioned age earlier. Does the age, the hypertension starts give a clue to the cause of the RAS?
It can, yes. If hypertension starts after age 55, particularly in someone who already has coronary artery disease or peripheral vascular disease.
It's just atherosclerosis.
Exactly. That's the most likely cause. But if you see new hypertension in someone younger, say under 30,
Think FMD.
think fibromuscular dysplasia. It's a much more likely explanation in that age group. Oh, and the notes also break down severity. Moderate stenosis is 50-70% narrowing, severe is over 70%, and then there's total occlusion, which is 100% blockage.
Right, useful classifications. So let's say we suspect RAS. What's the workup? How do we actually investigate and confirm it?
Okay, you'd usually start with some basic bloods and urine tests. Serum creatinine is crucial to check baseline kidney function. Serum potassium check for any electrolyte issues. A urinalysis gives you more information about kidney health in general, and you might check an aldosterone to renin ratio.
To help rule out primary hyperaldosteronism.
Exactly. Helps with that differential diagnosis we talked about.
Okay, initial tests done. Then imaging, presumably?
Yes, imaging is key to actually see the renal arteries. Duplex ultrasound is often the first choice, especially if you have a high clinical suspicion.
And there are specific things you look for on the ultrasound.
Yeah, specific Doppler criteria. These numbers are worth trying to remember for exams. You're looking for things like the ratio of peak velocity in the renal artery compared to the aorta, if that ratio is over 3.5.
Okay.
Or a peak systolic velocity in the renal artery itself over 200 centimeters sec, usually with turbulence noted. An end diastolic velocity over 150 centimeters sec is another sign. And a high renal resistive index over 0.8. These basically quantify how disrupted the blood flow is.
Those are quite specific numbers. Good to flag those. What if ultrasound isn't clear? Or for other situations, are there other imaging options?
Yes. If the patient doesn't have significant chronic kidney disease, then CT angiography, CTA, or MR angiography, MRA are good options. Sometimes a captopril renal scan is used, though maybe less common now.
And if they do have CKD?
Then you're usually more cautious about contrast dye. So non-contrast MRA might be preferred to avoid any risk to the kidneys.
Okay. When would you move to something more invasive?
Well, the gold standard, the most accurate test, is conventional renal angiography.
Catheter-based.
Exactly. It gives the clearest picture, the highest sensitivity and specificity. Plus, you have the option to intervene right then and there, like putting in a stent if needed.
Right.
But because it's invasive, involves catheters, contrast dye, you typically reserve it for cases where the non-invasive tests are inconclusive, or if you're pretty sure you'll need to do an intervention anyway.
Okay, makes sense. So let's say the diagnosis is confirmed. How do we manage renal artery stenosis? What's the approach?
Right. Management is usually multifaceted. It involves lifestyle changes, medications, and sometimes those interventional procedures we mentioned.
Lifestyle first.
Always important. Good blood pressure control is paramount, obviously. Smoking cessation is non-negotiable. Managing cholesterol levels, these apply to pretty much everyone with RAS.
And medication-wise?
Antihypertensives are absolutely central. The target is usually less than 130 over 80 millimole each G.
Standard target.
Yeah. Often you'd start with an ACE inhibitor or an ARB, but you need to be a bit cautious, especially with bilateral stenosis, as they can sometimes affect kidney function in this context. Then you might add diuretics, beta blockers, calcium channel blockers, whatever's needed to hit the target. Antiplatelet therapy, like low-dose aspirin, is usually recommended, especially if it's atherosclerotic RAS.
And specifically for atherosclerosis.
Yeah, beyond the blood pressure meds and aspirin, a high-intensity statin like atorvastatin is really crucial to manage the underlying plaque problem.
And for FMD, is it different?
For FMD, the main medical focus initially is just really good blood pressure control with antihypertensives. Statins and aspirin aren't typically standard unless there are other reasons.
Okay.
Yeah.
What about the non-drug treatments, the interventions?
Right. So lifestyle, as we said, for everyone, low-salt diet, weight loss if needed, stop smoking, good diabetic control. Then for procedures, if it's FMD causing the problem, the first-line intervention is usually percutaneous renal artery balloon angioplasty.
Just stretching the artery open with a balloon.
Essentially, yes. For atherosclerotic RAS, or sometimes FMD that doesn't respond to angioplasty, renal artery stenting is often considered.
When would you typically opt for a stent?
It's usually second line. Indications include hypertension that's still uncontrolled despite multiple meds, worsening kidney function. That acute kidney injury you can sometimes see when starting an ACE inhibitor or ARB.
Right.
Those recurrent flash pulmonary edema episodes, if there's significant stenosis in both arteries, bilateral RAS, or if someone only has one functioning kidney and it has RAS.
Yeah, and surgery.
Surgical revascularization, like a bypass graft, is generally a third-line option. It's more invasive, so it's often reserved for complex cases, or may be done if the patient is having major aortic surgery anyway. The key takeaway is that the treatment really needs to be tailored to the cause atherosclerosis versus FMD and the patient's specific situation.
That tailoring seems crucial. What about the long-term picture? What's the prognosis like for patients with RAS?
It's quite variable, actually. It really depends on a few things. How severe the stenosis is, what other health problems the patient has or comorbidities, and importantly, how well they respond to whatever treatment plan is put in place.
But there's hope for improvement.
Oh, absolutely. The good news is that getting a prompt diagnosis and starting appropriate management can definitely improve outcomes. It can slow down kidney damage and reduce the risk of complications.
Which brings us to complications. What are the main risks if RAS isn't managed effectively?
Well, the big one is uncontrolled hypertension itself, which is a major risk factor for cardiovascular events.
Like heart attack and stroke.
Exactly. Plus, the reduced blood flow and high pressure can lead to progressive kidney damage, potentially even kidney failure requiring dialysis. Heart failure is another significant risk, partly due to the chronic high blood pressure and fluid retention.
Okay, so definitely serious potential consequences.
Right.
Right, let's try and crystallize the key takeaways for MSRA revision.
Okay, summary time. Definition. Narrowing of renal arteries, less blood flow to kidneys. Causes, mainly atherosclerosis, older vascular risks, and FMD, often younger. Pathophysiology, kidney senses low flow, activates RAAS.
Leading to vasoconstriction and saltwater retention.
Causing hypertension, remember key differentials. Other secondary hypertension causes like primary hyperaldosteronism, renal parenchymal disease, epidemiology, more common in older folks, those with hypertension athero risks. Clinical clues. Resistant hypertension, worsening kidney function, flash pulmonary edema, that abdominal bruit.
Especially hypertension onset 55 or 30 FMD.
Yeah. Right. Investigations start with bloods, creatinine, potassium, urine. Then imaging duplex ultrasound is key. First line, remember those velocity criteria, 3.5 ratio, 200 PSV, 150 EDV, RI, 0.8. Then maybe C-TAMRA. Angiography is the gold standard, but invasive.
Management. Lifestyle is foundational. Meds include antihypertensives, target third tier 80, antiplatelets, statins for atherosclerosis, interventions, angioplasty often first for FMD, stenting for refractory cases-specific indications in atherosclerosis, surgery is third line.
And finally, prognosis varies, but early treatment helps. Complications include uncontrolled hypertension, kidney failure, heart failure, cardiovascular events.
Excellent summary. It really highlights how something seemingly localized in the renal artery can impact the whole cardiovascular system and kidney health.
It absolutely does. It's a great example of that interconnectedness in the body. Understanding that link between vascular supply and organ function is so important.
Definitely food for thought. Well, for everyone listening and wanting to dive deeper into renal artery stenosis or any other MSRA topics, make sure you check out pastthemsarea.com and also freemasarea.com.
Yeah, great resources there. Lots of practice questions.
Absolutely.
Yeah.
Thanks for joining us on this deep dive today.